everyone, I'm Carly. I'm one of the interns. I thought it would be good to do a presentation on just like how to read a CT abdomen pelvis instead of just staring at it blankly or looking at the read and then looking at it yourself. So let's go through it here.
And you can just click the.
There we go. So the main thing to know is like, it's a process. You can't just like willy-nilly look at it. You really have to like teach yourself to be really systematic about it in order to like actually find all the findings that are there. And so the process I'm going to go through today is kind of something I saw online, but something that I thought was just like the easiest to remember. Like first looking at all your major organs, then going through your GI tract, then looking at your vasculature. And then the one thing we won't talk about is like technically there's a step 4 of just like look everywhere else, like in the skin and the muscle and everything, but we're going to skip that today. Okay, so let's talk about our major organs. So the way that I think is easiest to go through them is just like scrolling kind of from the top to the bottom. You know, you're always going to notice the huge liver first, then moving to your gallbladder, switching to the other side, doing your spleen, and then kind of going through the middle, your pancreas, your kidneys, and then scrolling down to the bladder. And when we think about our major organs, there's kind of like 4 characteristics that you can kind of just like go through your mind and think about these for each one. So like, is it an appropriate size? Is it the right shape? Does the density look right? And then homogeneity, which is kind of one of the biggest ones. Like, is there a large stone in this kidney, or are the borders of this organ clear? So we'll go through this for each one. So first, we're going to start with our liver. And 2 of the characteristics that are most important are the density and the homogeneity. For the density of the liver, you can compare it to surrounding things. You want to compare it to the spleen and the muscle, and you want your liver to be a little bit brighter than these things. And then for your homogeneity, you want to kind of be able to trace the borders. They should be very smooth. And then you want to look inside. The only kind of abnormalities you should see is vasculature. Other than that, all the tissues should look the same. So let's look at an example here. So on the left, you'll see normals, and then on the right, abnormals. So on this one, it's abnormal in that the density is different and the borders are different. So when we look at the density, we're comparing it to the spleen and the muscle, and we can see the one on the right, the liver isn't as bright. And then when we look at the borders, we see they're not as smooth and regular. And this is an example of cirrhosis. So in a patient who may not have this diagnosed or may not have a biopsy, you can kind of see this just on a CT scan. Another example of the liver, this is a trauma example. So kind of on the left side here, we see that it's not fully homogeneous inside. And this is the example of a liver laceration. Okay, so when you're done with your liver, you can just scroll down right next to your gallbladder. Important things here: size, shape, homogeneity. So size is for your wall. It should be less than 3 millimeters, just like how we use on ultrasound. The shape should be kind of like this pear-like structure. And then obviously we're looking, are there stones inside? And then what does like the surrounding tissue look like? So here's an example: normal on the left, abnormal on the right. On the right, you can see the border. And I think, you know, I'm not really sure how to measure things on CT, but if you just look at it, it looks so much bigger because you can actually really see the border well. The shape, it's a little more circular, and that's pretty non-specific, but just something that can kind of cue you in. And then the homogeneity. So obviously here we see like the big stones, like no one's gonna miss that. But we also see, this is like our first example today of fat stranding, which is kind of a hard concept, and I think something you just have to get used to looking at. But I think especially when we're comparing like this normal here, where the tissue around it is just, you know, there's nothing fancy about it, but here we see kind of all this inflammation and just like gunk kind of crowding the area, and that's how I like to think of fat stranding. And this is an example of cholecystitis. Okay, so we are done with our right upper quadrant. We can go over to our left, and here we have the spleen. Everyone's spleens are different sizes, so there's not too much on the size, but normally they should be less than, people say 14 centimeters. Taller people will have larger spleens. The shape, and I thought this was interesting, normally our spleens are concave, but when they're enlarged, they're going to take on more of a convex shape. And then obviously, again, the homogeneity. What does it look like on the inside? So this is an example here of a splenic laceration in trauma. So we see on the inside, the tissue is not all the same color, we see this area here, which is the bleed. And then this is just another splenic laceration. So there's different gradings you can do, 1 through 5. This one, first one, was a grade 1, where it's just very tiny. And then here you have a grade 4, where kind of there's very little remaining normal splenic tissue. And then just because we have so many sickle cell patients, I thought this would be a good example to look at. So here we see abnormal in size, you know, it's almost as big as the liver. The shape, it's kind of starting to get that convex shape. And then the homogeneity, it's a little hard to see, but there are darker areas, which is your splenic sequestration. Okay, so we've done our size. Now we're going to kind of go to the middle of the abdomen, look at our pancreas. And the big thing here is just looking at the homogeneity, looking at the borders and looking inside. So on the right, on the left here is normal, and you know, you can kind of trace all the borders here pretty well. But on the right here, we see like things kind of get a little fuzzy. They get a little hazy. They're not as easy to trace. And then we kind of see the tissue around. It also has that hazy, that gunkiness. And so this is an example of acute pancreatitis with fast drafting. Okay, kidneys. So kidneys, we want to look at the density, the homogeneity. And kind of what your kidneys look like is going to depend on where during the contrast, if you did contrast there, how they light up. So kind of moving from left to right is no contrast to like further delays in the contrast. And this is why I think our radiologists are always so stuck on like doing a non-con CT if you want a stone, because you know, if there's a little stone right here, you are going to miss it. But if it's a big stone that takes up a larger space, you know, you'll still be able to see it on the contrast CTs. Instead of showing a stone, you know, that's kind of boring. So I thought I would show another trauma example. And I think one thing that's interesting here is obviously we see this big hematoma here. But another thing that's interesting is the echogeneity is different between these two kidneys. This kidney isn't as hamstring as much. And when you see this in a patient, like this patient from this case report I read, a few months later, they came back with very uncontrolled hypertension because one of their kidneys wasn't functioning as well. And so that's just something interesting you could look at today and know that this is going to have very long-term effects for your patient. Okay. And then you would want to trace the kidneys from the kidneys down the ureters and into the bladder. The bladder, there's not too much to look at. It's mostly just the size. Is this a big bladder? Is it small? But it's also going to depend on when your patient last used the bathroom. And then do you see any stones inside? And in a trauma case, maybe you're going to wonder, hey, where is the bladder? So if your bladder is missing, it might be a sign that it's ruptured. There's different grades of ruptures, if it's intraperitoneal or extraperitoneal. But just, I feel like we forget about the bladder, and it's something to always think about. Okay, so we've done our solid organs. When we're scrolling through, we started with the liver, down to the gallbladder, going to the other side, the spleen, and then down to our organs in the middle, pancreas, kidneys, and bladder. Now the GI tract. So kind of like there were principles to our organs, there are principles to our GI tract. We want to look at the walls, we want to look at the lumens, and then obviously look if there's any like masses inside. And just a little GI tract anatomy. It's important to know kind of where the twists and turns are. That way you can really like follow through your bowel. So talking about the small bowel, you'll start in your stomach, trace through the duodenum. I forgot that your duodenum does this like long straight line across your abdomen, and then it'll kind of jump down. And you should be able to trace it pretty well through the stomach and the duodenum, and then you'll kind of lose it in the middle and won't be able to follow it, but that's fine. And then I found that the easiest way to trace the large bowel is to start at the bottom. You want to go from the rectum up to the sigmoid colon, go up your descending colon, across your transverse, and then down your ascending colon. So let's see, I have a little video here, because this is more of like a dynamic process, because you really need to.
The one thing that would get
We're gonna watch this out.
like Ryan. So we have the vitamin D, a good coffee.
Okay, we're gonna watch along.
If you text me to meet you in like 5 minutes, I'm gonna go. Make your move.
The first thing I do is I follow the GE junction or the distal esophagus down to the GE junction through the stomach. Follow around to the duodenum. And I follow the duodenum across midline. Pass a little bit of Tract to the first portion of the jejunum. Then I check out my spleen over here.
Okay. So if you can see, like you have to do a lot of like scrolling back and forth because things are going to take different like twists and dives. And then we'll go a little further. Large ball is a little more exciting to watch.
I tend to go in a retrograde manner. So I start the rectum. Follow the rectum up. Come across the sigmoid. Take a nice little turn backwards. We have our ascending colon coming up, coming up. Now we're the splenic flexure. Here we're coming across the transverse colon here. The hepatic flexure. Descending colon. Now we come down to the ileocecal valve and our nice little appendix down here. There it is. And I'm just coming across. This is pretty long appendix, comes all the way midline.
But again, yeah, it's a lot of scrolling and kind of just remembering where all the twists and turns are, but then also realizing that like every patient is different and everyone's valves are going to be in different places. Okay. And then just a few things to look at, changes in your bowels. So first, like small bowel obstructions. So you want to look for dilation proximally and then collapsed distally. And then you want to look at things like wall thickening and then how thick the actual bowel is. So for a small bowel, it shouldn't be any more than 2.5 centimeters. And then looking for like surrounding edema and ascites if possible. For a large bowel, it's kind of the same idea here, except instead of 2.5 centimeters for small bowel, we're thinking more about 5 centimeters for large bowel. And then another thing, you know, there's a reason we don't see large bowel obstructions very often. They're very uncommon. And so if you do see one, you kind of need to think about why your patient has one. So you want to think about malignancy, volvulus, like diverticulosis, or some of those common things. Okay. And then everyone's favorite thing, the appendix. I thought this picture on the right here is really interesting. It just shows like your appendix can be in all these different locations. It doesn't follow like a good rule. It can go under muscles, it can go over muscles, it can be more in the line of your umbilicus, or it can kind of be all the way down to your groin. So it does take a little searching. Kind of the normal sizes, you want the wall to be, each wall to be less than 3 millimeters and the whole thing to be less than 6 millimeters. So here's a normal one, and it's normal to kind of see some air in it because it's just like an empty tube. So here it is on the right, the abnormal. And I think the biggest thing here is just how large it is. Like this is really small, and if you measure this, it's definitely gonna be way more than 6 millimeters. Okay. And then just 2 last examples I want to talk about, just free air. So you're going to be looking for black is air, and one thing you can do is actually switch to your lung windows because those are great at looking at air. So this is a lung window on the right, and it just becomes way more clear. Things to think about in patients when you're worried about perforation. And then because of air, I was thinking about, well, what's the difference? What would ascites look like instead? And ascites is going to be, it's not going to be black. It's going to be more of this gray gray color all around here. Okay. And then vasculature is just real quick. You're kind of looking at how large things are, and then, you know, is there anything inside of it? Is there a big clot inside of it? Looking at our IVC, you don't have to think about too many branches, which is nice. You just kind of look at your renal veins and then into your common iliacs. Here is a pretty good example, and these are great to look at in the coronal view because sometimes you can see the whole thing right here. So here we see the IVC is getting bigger, and then we see this big clot inside of it. Arterial, there's more branches to think about, unfortunately. So you're thinking about your celiac trunk at the top, feeding like your spleen and your liver, going down to your renal veins, kind of the same level as your SMAs, and then your IMA lower down, all the way down. And obviously, looking at how large things are. So this is an example of an abdominal aortic aneurysm, kind of hard to miss sometimes. And then thinking about if you can happen to catch a dissection in your abdominal CT as well. Okay, so it really didn't take that long. This is something we should probably do more often on most of our abdominal CTs. You know, if we can talk through it in 15 minutes, then you can probably do it on your own in like 2 minutes. So just kind of remember, everyone's going to have their own system. I kind of like this one because I don't think you're going to forget to do anything. I think there's ways to do it really efficiently where you minimize how many times you scroll from the bottom to the top. Mine might be less efficient that way, but I don't think you're going to forget to do anything. So just going through for our major organs, we thought about like how big they were, what size they were, what kind of density they had, and then if the inside was homogeneous and if the outside was homogeneous. For our GI tract, we just looked through it, following it, if there's any dilations, if there is any signs of infection, and then your vasculature, just following the diameter, making sure it's even, and then looking for big clots or tears on the inside. And that's it. There are a lot of very good CAT scans and CAT jokes online.
Any questions, comments? I think one thing that kind of helped me is the 3-6-9 rule. So kind of along your 3 for small bowel, 6 for large bowel and appendix, and then 9 for cecum. It's like it's easy 3-6-9 rule. Yeah, really good job. Okay. So.